Going on, we welcome everyone today. We're delighted to have Celine Saunier, who is an adjunct associate professor from Emory University School of Medicine, and who is the current author of The Vineland, the third edition. The Vineland's been around now for quite a while. The second edition was really a landmark in the field, and I think The Vineland has become the most widely used psychological assessment instrument in the world. And Celine's going to be talking about using the Vineland in autism and looking at adaptive skills. So Celine, take it away.
Thank you so much, Fred. Thanks for having me and everyone for joining. I so wish this was in person so I could see everybody. So it's nice to see you here. I'm so thrilled to give this talk, and about the Vineland. It was considered the gold standard far before I had anything to do with it. So I still do have to disclose that I receive royalties for that and for the 2 books that I have with Wiley, and also that I consult on numerous clinical trials that use the Vineland as an outcome measure. So I just wanted to start with defining adaptive behavior. I'm sure all of you are very familiar with this construct, but it's the performance of skills that are necessary for our personal and social self-sufficiency. So it's the skills that we apply that are in our repertoire when life demands the skill. So ideally, we are doing this with complete independence, which is why it's measuring self-sufficiency. So that means without the help, support, prompts, or reminders from another person. And as you can imagine, with the range of capabilities of many individuals with across disabilities, let alone typical development, this everyone has their own capacity for self-sufficiency. So we just want to optimize that adaptive behavior for everyone. So just as an example, you can see in this photograph that one of the girls has independent figure skating skills and the other not so much. And the nice thing about adaptive behavior is that if you don't have a skill, but it's within your capacity to develop the skill, then that individual is quite capable of developing the skill very, very quickly. So to distinguish this from cognition, cognition is more stable over time. These are your skills that are either innate or acquired, and it's your repertoire of skills, your optimal capacity. So remember that adaptive behavior then is applying those skills or translating those skills in real life with independence. So if you think of cognition as what a person can do, what they're capable of, think of adaptive behavior as what that individual actually does independently. So for the past 10 years plus, I have used the example of my own daughter and hoping that someday this won't be an example, but it still is. If someone asked me, can my 13-year-old daughter brush her teeth? I would say, yes, absolutely she can. But if an astute clinician conducting an interview of adaptive behavior said, oh, you just said that your daughter can brush her teeth, what percentage of the time does she actually do that on her own without you having to remind her 150,000 times and then chase her around the house with the toothbrush and the toothpaste every single day? Then I would say, well, yeah, not so much. That's about 0% of the time. So there is quite a difference. And the reason I emphasize this so much is because in autism, there is this striking gap between an individual's cognitive capacity and their ability to just naturally apply the skills that they have in a meaningful way. So you think about this in all of the individuals that have a lot of verbal skills, yet they can't just say, hi, mom, how was your day? And apply those skills in a nice way, in a nice, independent way. So distinguishing what an individual can do from what an individual actually does. The characteristics of adaptive behavior are that they're age related. So younger children, obviously infants and toddlers, have a different repertoire of functional skills than teenagers, adults, and older individuals. They're defined by the expectations and standards of others, and they're defined by the typical performance, not optimal capacity. What's wonderful about adaptive behavior is that it's modifiable. It can change over time and it can change quite quickly. That can be through intervention. That can also be through lack of intervention, maybe through trauma. So we can identify if there's a deficit and then teach a skill and then hopefully see it acquired. And then it's one of those areas where you want your adaptive functioning to be solidly age appropriate, adequate. We're not striving to have advanced adaptive skills. And that's because we don't want a 5-year-old roaming the streets of a city independently or driving a car. So when you see high adaptive skills, it should be a red flag. Why is this so high? We can definitely see this in more conceptual adaptive domains like communication, if someone has advanced verbal skills or cognition. But for daily living skills, for example, if a very young child is cooking and cleaning and doing all of the household chores and taking care of their younger siblings and are a parentified child, that would raise a red flag of why is that the case? So when we talk about adaptive functioning, we naturally also have to talk about levels of intellectual functioning. And so defining intellectual disability. And in just about every diagnostic system, the definition for intellectual disability are both delays in cognition and delays in adaptive behavior. So you have to have both of those. The current DSM-5, the Diagnostic and Statistical Manual, defines adaptive deficits in the areas of communication, daily living, socialization, and independent living. So there's no motor skills defined in the DSM currently, which when we talk about, for example, the Vineland, is why there's not such a focus on motor development anymore. Now, for those of you that remember all of the DSM criteria prior to the DSM-5, any definition of intellectual disability had severity levels of mild, moderate, severe, and profound. And they used to be keyed into the cognitive level. So if someone's IQ overall was 65, for example, they fell in the mild range. However, that all changed in the DSM-5, and now the severity levels are much more keyed into adaptive behavior and how much support is required per individual. And that actually is way more useful in determining how to intervene. So this is a wonderful article, if you haven't already seen it, that talks about the behavioral indicators for intellectual disability. And just to kind of blow this up, you can see for mild, moderate, severe, and profound across development, early childhood, adolescence, and adulthood, what benchmarks we can say, okay, this is what it means for mild, this is what it means for moderate and severe and profound. How much support does that individual need? And then when we think about the autism spectrum, it is now so incredibly broad, as all of you know. It's, in my view, too broad in many cases, that we're not just talking about levels of autism symptomatology, the social communication, interaction, play impairments, and the restricted and repetitive behaviors, how severe or mild those are. We're talking about co-occurring conditions of cognitive impairment, language impairment, and then any medical or psychiatric co-occurring conditions. So when people talk about quote unquote high functioning autism or low functioning autism, they're talking about usually levels of intellectual functioning. And I try to move away from those terms, because someone can certainly have intact cognition and language on the autism spectrum, but have debilitating vulnerabilities nevertheless. So they require significant treatment, intervention, and modifications and accommodations, despite having even very advanced cognitive and language skills. When we see individuals that do have co-occurring intellectual disability, we tend to see more medical co-occurring conditions like seizures, cardiac defects, metabolic conditions, identifiable genetic mutations. Whereas when someone has intact cognition and language, we tend to see more of the psychiatric co-occurring conditions, most significantly anxiety, and then certainly depression, and on the rise suicidality. And when we think about it, might have into your vulnerabilities, the more aware you might be of when you have failed social interactions, or if someone is ostracizing you, or you're being rejected by your peers. So that therein lies these co-occurring psychiatric conditions. So just to talk a little bit about the history of adaptive behavior, Edgar Dahl in the early 1900s was one of the first to talk about this construct of adaptive functioning. And he was working at the Vineland School. It was then called the Vineland Training School for the Feeble-Minded Boys and Girls, and it was in Vineland, New Jersey. So that's where the name came about. And he was among all of the psychologists that were really focusing on cognition and intelligence, and how that was the end all be all for someone's importance in society. And Edgar Dahl was observing that even in these intellectually disabled individuals, they had a lot more to contribute to society than just their cognition alone, and their social functioning meant so much. And so he talked about social competence and social maturity. So he developed what would become the very first standardized measure of adaptive behavior, and it was called the Vineland Social Maturity Scale. And given that he was working with very impaired individuals, he developed this measure as an interview that was conducted with a caregiver, a family member, a third party respondent, because the individual themselves could not speak to their adaptive functioning, nor could you in a clinical setting really assess the breadth of real life skills beyond the confines of your clinic. So thinking about community behaviors, in-home behaviors. So he really stressed the need to do this as an interview with a third party informant. And then if you look at the history of how we define intellectual disability, every single diagnostic system since the mid 1900s has defined ID as both delays in cognition and adaptive behavior. So this really drove the need to have more standardized measures of adaptive functioning. And so this called for an update of the Vineland Social Maturity Scale, because it was published in the 1930s. And that's when they found our Sarah Sparrow at the Yale Child Study Center, who was a guru in intellectual disability, to have her update this measure. And as you well know, her husband, Dom Cicchetti, was a biostatistician, and together they developed this update with then David Bala. And so they kept true to Edgar Dahl's whole form of the assessment. It came out solely as an interview that was conducted with a third party. And the first publication anyway, it wasn't until it was updated in its second edition and then taken over by Pearson Assessments that a parent caregiver alternative, a rating scale, was provided. And so if you ever asked Sarah, how should you assess adaptive behavior, she would wholeheartedly say, if you can, certainly do the interview. So this importance of the interview has really kept true to the Vineland, and the Vineland, even in its third edition, still remains one of the only measures of adaptive functioning that is done by an interview. And it really does not just allow you to get a breadth of information that goes beyond just adaptive behavior, but it also allows you to protect against, possible misrepresenting by someone if they're trying to represent their child in a positive way, or maybe represent their child as having more impairments than they do, or even just misunderstanding what adaptive behavior is and only reporting on the rating scale what their kid can do rather than what they actually do. And if Dom were here today, he would love this graph more than anybody, this chart of the Cohen's D values. Pearson drafted this just to sort of elucidate how much the interview is better at differentiating the clinical groups in comparison to the normative sample, especially in autism and intellectual disability. So the higher the Cohen's D value, the better every item is differentiating a clinical group from the typical standardization sample. And as you can see, the numbers are higher for the interview than the parent rating form. Of adaptive behavior now, the most widely used are the Vineland-3 and the Adaptive Behavior Assessment System, both in their 3rd edition. And then the newest one is the Diagnostic Adaptive Behavior Scale that was published by AAIDD. And the ABIS, which is widely used, is solely a rating scale. The difference, they both span the lifespan, but the difference with the ABIS is in the adult form, you can give it as a self-report, whereas the Vineland does not have a self-report option right now. And so I, as a clinician, I see many, many adults in my private practice for first-time autism evaluations. So when I want their self-report, I actually will give the ABIS, even though I'm an author on the Vineland. So this is the structure of the Vineland. It's assessing adaptive behavior in the areas of communication, receptive, expressive, and written, daily living skills, your personal care, your domestic care, and your community skills, socialization, your interpersonal relationships, your play and leisure skills, and then your coping or behavioral regulation, emotional regulation skills. And then optional now are the motor skills, fine and gross motor. And that's optional now and not included in the overall adaptive behavior composite because, like I said, motor deficits or motor delays are not part of the diagnostic criteria for ID in the DSM-5. And then the Vineland also has a maladaptive behavior index that's kind of a broad screening for internalizing, externalizing behaviors like anxiety, depression, more of your ADHD, disruptive behavior type things, but really a broad screening. And the Vineland has the interview form, the parent caregiver rating form, and then a teacher form. And then all 3 forms have a comprehensive version that has, all of the items across all of these 11 subdomains and 4 domains. But then there's also what's called a domain level version, which is a briefer version that is given solely for eligibility services. So if you're a diagnostician that is only doing ID evaluations to determine does someone have intellectual disability or not, the domain version is suited for that. It's not supposed to be something that's given for more comprehensive intervention planning. And then all 3 forms, you can also use the very old or antiquated paper forms, or you can use the new online editions where you are actually administering it online and the computer is compiling the basals and ceilings and scoring everything for you. It's so much easier to give online, in my view. So now to talk about profiles of adaptive behavior in autism, I emphasize the Vineland because the vast majority of research to date on adaptive behavior in autism has been done using the Vineland worldwide. And with Fred Volkmar, Alice Carter, Sarah Sparrow, we're dating all the way back to the original studies on the autism profile that showed the greatest areas of deficit and adaptive functioning in autism were in the socialization domain. And that the majority of individuals with autism would have these delays or deficits in adaptive behavior. What we're finding out more recently are that the delays in adaptive behavior seem to be greatest in comparison to IQ in individuals who have intact language and cognition. So the gap is that here's your language and cognition skills, and then there are severe gaps in and delays in your adaptive behavior. Whereas in individuals who have intellectual disability, their profiles of adaptive functioning tend to be more on par with their mental age. And we'll talk about why this might be the case in a minute. And that this gap between cognition and adaptive functioning seems to be bigger in older individuals versus younger, and it appears to widen with age. That doesn't mean that there's a regression or a loss in skills. It just means that the rate of acquiring new adaptive skills is slower than the rate of acquiring conceptual skills for cognition. So a typical Vineland profile in someone with intact cognition looks like this, where you can see that overall the scores are below not only age expectations, but certainly cognitive expectations, whereas you're going to see the greatest areas of delay in the socialization domain. You can see this across the spectrum of range of functioning, that the written domain is going to be inflated. And this is because autism loves letters and numbers and reading and writing, things that stay constant and the same over time. So when you see this, just keep in mind that it's inflating the overall communication domain, and that if there are true receptive and expressive delays, you want to make sure that those are highlighted. So in talking about the early research that my colleagues and I did at Yale way back when on adaptive behavior, and this is with Sarah Sparrow and Dom Cicchetti, we were looking at specifically only boys that had intact cognition and language from the ages of 8 to 18. And we were struck by how deficient their adaptive skills were in relation to their IQ, because they were supposed to have the most potential for success, having intact cognition and language. And yet their socialization skills were more than 3 standard deviations below their age and IQ. And so we were so struck by this difference that we enlisted Kathy Lord, who was then at the University of Michigan, to analyze her data, and we found the same pattern. And if we split this sample by age and looked at the 8 to 12-year-olds versus the 12 to 18-year-olds, we found that the older individuals had a larger gap than the younger individuals. But that was a cohort sample, so we couldn't say anything about a longitudinal effect. And then my colleagues from the Simon Simplex collection, we looked at this in a much bigger sample of over 1,000 individuals that included males and females. And we looked at this gap in age and split the sample by the 4 to 8-year-olds versus the 9 to 16-year-olds. And you can see here on the left, if the blue is the younger sample and the green is the older sample, they had no difference in cognition despite the age differences. Yet the older sample across the board of Vineland scores had lower scores. So their gap was greater than the younger individuals. So then my colleague Kasia Havarska, we presented this at INSAR so many years ago, and I wish we had published this at the time. We had looked at in the early detection studies, children at the age of 2 who were then followed up at 4 for diagnostic confirmation, and then several years later got an additional grant to follow up those same individuals at age 8. And now we could look longitudinally at their adaptive development in comparison to their cognitive development. This graph here is looking only at the individuals by age 8 who had intact cognition, meaning their IQ was over 70. And you can see here that at 2, their estimated IQ based on Mullen scores was actually delayed. But by the time they were 8, they had closed the gap in their conceptual development, which is amazing. Yet you can see over time, their adaptive skills overall had not kept pace in development with the same consistency. So that gap between 2 and 8 was actually increasing over time. Now, if we look at those individuals who by age 8 had intellectual disability, they had a very different profile. Their adaptive scores were actually above their mental age as estimated. And there are several reasons that could be the case for this. We did not do a treatment study. We were not analyzing treatment in any of those studies done. So this could be a treatment effect. Many of us who do diagnostic evaluations, anytime we identify someone with an intellectual disability or cognitive delays, we just very naturally give recommendations for adaptive functioning. Teach these individuals how to dress themselves, how to have toileting skills, how to brush their teeth, how to count money, how to take public transportation. But we very rarely give those same needed recommendations to individuals who are extraordinarily bright. But this also could just be effect of the measures. So in trying to identify when this gap begins, many of you probably remember Jessie Bradshaw. Jessie was a research assistant in Kasia Havarska's lab in the infant and toddler clinic at Yale. She then was at Santa Barbara, and then she came to work with me and my colleagues at the Marcus Autism Center in Emory University as a postdoc, and now she's on faculty at the University of South Carolina. So we looked at the infant sibling studies. These are the babies that we're studying from birth who are younger siblings of someone who already has autism in the family. And that means they're at greater familial risk of developing autism on their own. It's a 1 in 5 risk that they will develop autism. And then by comparison, looking at low risk infants who have no autism in the family. So when we did this, we're using Mullen scores, the visual reception domain of the Mullen, so an estimate of nonverbal cognitive reasoning with the interpersonal relationships subdomain of the Vineland. So we're looking at nonverbal cognition in comparison to socialization skills. And these are age equivalents, so they are going to increase over time in these babies between 12 months and 36 months. This is the typical group, the low risk group, their nonverbal reasoning. You can see over time that they actually had above average nonverbal reasoning skills. Now, remember how we don't want adaptive skills to be above average, and we had very well-trained research staff on conducting the interview. So their interpersonal skills were solidly age appropriate, but not above average. So we see a parallel gap there, but that's an expected gap and it's parallel. Whereas the children who went on to develop autism, the high-risk infants, they too had above average nonverbal reasoning skills, which is wonderful. But here you look at their interpersonal socialization skills, and their acquisition of skills over time lagged behind their nonverbal reasoning. So the gap did widen between 12 and 36 months. And this is widening prior to diagnostic confirmation. We did not confirm the autism diagnosis in these infants until 36 months. So this tells us something as one of these markers that can predict risk when we're looking at these babies at such a young age. So I also want to talk a little bit about executive functioning, because executive functioning is so associated with adaptive functioning. And executive functioning is such a broad range of skills. I can't get into detail on how many constructs fall under executive functioning, but attention, inhibition, working memory, being able to hold and manipulate information before organizing or planning a task, organization and planning in more broadly, concept formulation, shifting attention, mental flexibility, social cognition, verbal fluency, all of this falls under the umbrella of executive functioning. And so the research is just coming out more and more consistently showing that, of course, there are executive functioning impairments in autism. We're talking way more broadly than just ADHD or attention deficit symptoms. We're talking way more broadly than that. And that these executive functioning impairments are highly correlated with and found to predict adaptive impairments in autism. So we're seeing this association really very strongly. And if you read anything by Lauren Kenworthy and Liz Pellicano, you're going to see this coming out more and more. And so when you see this overlap in individuals on the autism spectrum that have co-occurring ADHD, that of course both conditions are going to have inattention, difficulty monitoring, difficulties with working memory and fluency in concept formulation. And that's why there has been such controversy on, can you diagnose both of these conditions at the same time? But the difference between it is the flexibility and planning deficits tend to be more autism, whereas the response inhibition tends to be more ADHD. So when we think about adaptive functioning and how quickly you can make progress, this is why adaptive measures are so good for clinical trials and treatment outcome, because we can actually see this change quickly. The Vineland actually has a way to track this progress over time, and it's only in the Vineland 3, and it's called a growth what you can, if you even just click on it in Q Global, for those of you who are familiar with the Q Global platform, when you're looking at least 2 time points, you can see if the growth or any change over time, it doesn't have to be growth, it could even be decrease in scores over time. If the growth scale value is significant, then you can assume that that change over time was meaningful. And this is really important for clinical trials that are trying to identify quote unquote clinically meaningful change. And so people should be talking about the GSV scores more consistently than I think they have. It's not a new statistic. The Bailey has been using GSV scores. Other measures have been using GSV scores for a long time. It's just where it was the first time we used it in the Vineland. So it's something to look at that change. Because if you see, especially in autism, you're going to see over time those standard scores staying the same, if not even decreasing because of that gap widening. But that doesn't mean the individual's not acquiring new skills. So if you're actually going to do research, you're more likely to use raw scores, age equivalents, and growth scale values to look at that meaningful change rather than changes in standard scores. And to see how quickly adaptive skills can change over time. Many of you know Yale's own Larry Scahill, who's now at the Emory School of Medicine, and Karen Bears, who was at Yale and then Emory and is now at University of Washington, Seattle. They did their now just renowned parent training study that shows that parent training is an evidence-based practice in decreasing disruptive behaviors in children with autism. Yet a byproduct of their study was that in the 24 weeks that they were decreasing these problem behaviors or challenging behaviors, adaptive skills actually increased in such a short amount of time. And that was significant in comparison to their control treatment group. So just really emphasizing how useful it is to look at adaptive skills as an outcome measure. But then when we're thinking about individuals across the autism spectrum and what predicts good outcome, historically, and especially when I first started in the field, everyone talked solely about cognition and language. As long as someone had functional language and they had intact cognition by age 5, they were deemed to have the best prognosis for outcome. And yet, sadly, when all of these children aged into adulthood, we were seeing that that wasn't necessarily the case, and that so many adults are still struggling to hold down jobs, live independently, sustain successful relationships, and optimize their own outcome. And what we're seeing is that's because their adaptive skills and their executive functioning skills, they're still impaired. And people haven't realized to focus on and to foster those skills as much as cognition and language has been focused on. So Patricia Howland in the UK has probably done some of the most thorough adult outcome studies in our field. And she was looking at adults who had no cognitive impairment and looking at what was their level of independence into adulthood, and only 24% of her sample was meeting whatever that defined outcome was, holding down a job, living independently, etc. And when she followed those adults up later on, that percentage decreased. So what was going on here was that these individuals were not learning those functional adaptive skills needed. And so I love this article that came out of Australia a couple of years ago that, we've been thinking about for a long time. Please do away with this terminology of high functioning, because it really is a misnomer. Many of these high cognitive, high language individuals are still struggling so much, and they fall through the gaps in the treatment and intervention system because everyone thinks that everything else is so high. If they have such verbal capacity, they don't need to learn how to groom and how to use money in a functional manner rather than just do these outrageous calculations that really don't have as much meaning. So just really emphasizing here that and when we think about optimal outcome, my own mentor and advisor from University of Connecticut, Debbie Fine, her and Diana Robbins and Marianne Barton, they did years and years of studies on the MCHAT, diagnosing very, very young children prior to the age of 2, and then following them up over time. So it's the same group of expert clinicians conducting these diagnostic evaluations over time. And in doing those follow-up studies, they found these same expert clinicians were finding that by school age, there were a handful of their own participants that no longer met criteria for autism in the DSM. And by their own ethical clinical evaluations, they could not continue to give the autism diagnosis. And this was 10% of their sample. And they talked about this as optimal outcome. They were not talking about it as a quote unquote cure. They were just saying they no longer presented with the symptomatology. Every single one of those participants in the optimal outcome sample had intact language and cognition and intact adaptive behavior. And then I just want to stress that it's not only those individuals that have intact language and cognition that can achieve an optimal outcome. And I love this blog that was in Autism Speaks several years ago. And this is just reminding us that every individual has the potential for success, no matter what level of functioning, no matter how cognitively impaired or minimally to nonverbal an individual is, they have their own optimal outcome. And fostering that outcome is just so important, their own levels of self-sufficiency. And then when we're looking at newer research at employment and what makes someone on the autism spectrum successful in employment, that we need to focus on areas of strength as much as we're focusing on the areas of vulnerability. And that the more that we did focus on strengths, that was associated with these better outcomes. And then finally, just thinking about that for those of you who might work with school systems and thinking about individuals in the school systems and their educational programming, we need to be thinking about transition out of the educational system upon diagnosis, and thinking about how can we hone these strengths? How can we use circumscribed interests and areas of interest as a skill that can be a career? And really focusing on functional communication, not just acquisition of skills, focusing on how important those daily living skills are, even if they don't seem like they're at the top of the hierarchy. Like, I don't care if my kid can't dress themselves. Right now, I have to focus on speech, how important that is when someone's, applying for a job and needing to interact with the world in their own life. And so just also, I love John Elder Robison's quote here, you just have to make the transition from weird to eccentric to be okay. In this day and age, we no longer have to think about autism as a disability for everybody. We just have to think of it as a difference. And that social diversity, that's the spice of life. Certainly, there are individuals who have debilitating symptoms that we do want to ameliorate. We do want to foster and maybe even take away, right? The significant self-injurious and aggressive behaviors that are harmful to self and others. Certainly, we want to do away with that. but the social diversity, that's something we don't need to change, right? We just have to provide accommodations to navigate our social world, and then modifications, environmental modifications, so that the world is more accommodating and accepting to individuals across the spectrum. So with that, I just have these take-home messages that, adaptive behavior skills are essential for optimizing self-sufficiency. Everyone has their own level of self-sufficiency that should be nurtured. We want every behavior that's taught to be meaningful and applicable to real life, and know that adaptive behavior is modifiable. So we can change it very, very quickly. So if we teach it, they can learn. And just make sure that we're also focusing on honing areas of strength. So with that, I wanted to leave ample time for questions and discussions. But before that, I just have to thank, first and foremost, Sarah and Dom, whom I miss tremendously. I wish I could be there with you right now and see you. Cheryl Clayman and Jesse Bradshaw for all of their work in co-collaborating on books and articles on adaptive behavior, and Audrey Thurm at NIMH. She has been phenomenal in doing research with the Vineland, especially in these rare genetic disorders, and then Pearson Assessments and Wiley for their support in my writing. So thank you all so much. I miss you all so much, and I'll open it up for Q&A.
Celine, one of the participants wanted to see a slide again. If you could go back,
Sure.
I think it's probably slide 32.
This one?
I don't think that was it.
Did they say what it was on?
No, he thought maybe 33.
Okay.
Yeah, I'm not sure.
If that person's still on, feel free to jump on and ask.
Yeah. Yeah, he thought, oh. They're not seeing it right now.
It's
Well,
the Tassie person.
Oh, Tassie. Okay,
Thank you.
that's earlier. Yep.
Oh,
There we go.
oh, this was, yeah, no, this was a second one. Yeah, somebody was asking for this one that was then posted in the chat, the link, and then the other one, but we'll be posting your slides on the website, so
Okay.
folks can
perfect.
go through them. It'll probably be easier that way.
People can look.
Yeah.
Celine, thank you. This is a great talk. Anyone have any questions? I mean, I think one of the things that this whole body of work on the Vineland underscores is the importance of adaptive skills in terms of adult outcome. That,
Yeah.
as one of your slides indicate, that we used to always say, and I can remember hearing this from Donald and Maria way back when, the two things that predicted outcome were IQ and language, nonverbal IQ and language ability, present or absent, language, spoken language at age 5. And in point of fact, what we've come to appreciate are the other important variables of adaptive skills, and also for that matter, executive functions. Having been dealing more recently with people who are driving, if you want to drive, boy, you have to have your executive function skills pretty well organized. And if you don't drive, you're going to have a lot of trouble getting a job. So, we can help people do better and better, and are, but unless we teach these life skills, and unless we teach some of these organizational strategies, we're not going to be doing so well. But other people have questions or comments.
Good morning. I am a school administrator, but this topic is dear to me. I actually trained under Sarah Sparrow as a research assistant way back in the day, and gave many violence at the Autism Developmental Clinic. But presently I am in charge of a special education department. And one of the challenges that we have with parents is when we have to shift programming from traditional to more functional, and parents still hold on so dearly to academic skills, when we know that we need to put a lot of emphasis on just functional being. I was just wondering if there's really good resources in how to assist parents in understanding the importance of adaptive skills versus academic
Oh.
skills.
So, yeah, so the resource is everything here.
No, this is great.
And then if the book that Cheryl and I wrote on neurodevelopmental disorders more broadly, that I don't make any friends when I give presentations to school systems, when I say, you need to focus on this, like do away with academics. Because
Well,
these
I'm in full agreement.
individuals,
I'm with you.
yeah, and they're going to absorb the academics. They are absorbing the academics. And then I do this in the feedbacks with the parents too. And so like, just inundate them. And if it's not going to happen in the school system, find another place where you're going to teach and hone these skills, because once they transition out of the school system, it's very, very hard.
Very
It's
hard.
a lot harder to be teaching these skills from scratch.
Complete
I
agreement.
can. My name is Stephanie, and I'm actually a parent, and I'd like to comment on that because this talk has been really terrific and illuminating, and I really appreciate it. And my son is 20 now, and definitely falls within the high verbal, increasing adaptive gap. We're having really hard struggles with him in the last couple years that we didn't before. And so this has been really helpful to me. But on the point I wanted to make is that, I was very involved in Mark's IEP process throughout his schooling. And I really feel like it was the school eligibility process, where we were at least, was focusing more on the academics and less on the functioning. And that is kind of why it's steered that way. And I think because my son's verbal skills were so high, we actually didn't understand that he was on the spectrum at all. I mean,
Right.
I look back on it now and I think, was I asleep his entire childhood? Because I was very involved, and there was a lot of interventions, but we really didn't, exactly what you're saying. We really did not understand the importance of teaching him how to use money and all that thing, because we were all thinking, yeah, well, he's reading,
Yeah. Why wouldn't he get that, right?
the Animal Farm and whatever. And yeah, I am very appreciative, but I think that the school and the school has to also help the parents understand, because I'm an attorney, and I actually have done some special ed advocacy over the years, and I spent a lot of time trying to say, eligibility shouldn't just be based on the academics. But even with my own son, I didn't fully appreciate the importance of
Well,
it.
the schools, it's almost like the school systems are too rigid, because here in Georgia, you're on an academic track or you're in the special education, daily living. That's where you get your life skills track, and you can't be both. And that's unfortunate. And that's why I make no friends, because I'm like, you need to have both. Like, why should the students in the life skills program not have access to some AP classes if they wanted, and vice versa? Like this, there has to be a blend. We have to be flexible, because the disorder itself is not flexible, right? So we have to be the flexible ones. And I'll tell you, it is a fight. And it's systematic. It's not the teachers, it's not the parents, it's just a system-wide struggle.
Celine, we did have a question in the chat. Someone's asking, is there any research on outcomes of students who are mainstreamed but still require one-on-one behavioral support in high school? The support is generally hands-off, aides sitting near student with minimal need for intervention.
Research on outcome, that I'm less familiar with that research, and more so on the outcomes of the individuals who have the paraprofessionals that are on top of the kids that become prompt dependent and then not self-sufficient, right? They end up getting into the real world, and they are in constant need of another person. So they're not as self-sufficient. But ideally we want our students in the mainstream classes because they have the verbal ability, the social ability, and the cognitive ability to be interacting with all of their peers. It just needs to be explicitly taught first and practiced in that way. So if there is the one-on-one support for the more challenging skills, ideally that should then be fostered more broadly. And so how that actually manifests in the real world is different all over. And if you read any of the research on school programming that David Mandel does, it's just extremely hard to replicate any of these, experimental treatments out in the real world, and especially in the school systems.
We have a hand up, Marcia. Go ahead.
Yeah, I just figured I'd cue myself in that way. So I'm wondering if there's any new research coming out about adaptive skills due to specifically the heightened awareness that a lot of families got during the pandemic. Because I did a study that my colleague and I are finishing writing now, but we took a survey of of access to treatment and how many weeks it took so many families to receive adequate support when the pandemic came. Although we've had research for a long time saying telehealth is effective, the switch over initially was so disruptive to families, and it actually brought them sometimes with the silver lining moment of, wow, I'm now aware of some things that we really need to work on. Because when you're in the routine of, I send my child to school, then we go to therapy, then we do this, we have dinner, we go to bed, right? When you're in routines, the routines are almost so protective that you don't know until something happens where you discover some of those needs. And I think that it was a very ripe opportunity for a lot of families to say, we need to work on these things, but yes, systematically, we don't necessarily have the support in place for, right, like you said, the kids who are academically very strong, but still really need this adaptive teaching and intervention. So I guess twofold is there any new research that is kind of prompted by the pandemic to teach adaptive skills? And two, is there anything currently in place that serves as a good model that you're aware of for schools that do actually a very good job with this? Because as far as I am concerned, I haven't seen schools being very successful.
If anyone has seen a school, that please, it should be a universal model. So I think for the first one, the majority of the research I've seen come out on the pandemic has been about telehealth, really about how do we diagnose autism and identify it remotely, but then also on the mental health repercussions of the pandemic. So I haven't seen anything on adaptive behavior, but I have heard that rates of autism diagnoses have gone up, and same with ADHD, because to your point, parents are home 24/7 with their kids and experiencing everything like this. Anecdotally, I have had parents say, wow, I'm like working on adaptive skills now because part of the school is do the dishes, do the laundry, do this. So hopefully your research will be that. To your second point, I'm just going to open it up to everyone else. If you know of a good school model, please, please, please share it with the world.
Suzanne has her hand up, and then we do have one question in the chat, which I might be able to just send the message that way. Go ahead, Suzanne.
Hi, Lynn. Hi, thank you for such a fabulous talk. It was great to just get all those highlights of the work you did here on the Vineland. So it was great. My question is back to executive functioning. As you noted, these kind of fundamental skills are so vitally important to the development of adaptive skills. Do you, I mean, I know that the research, you know, there's just new research, a lot more research now coming out on executive functions. Do you have any sense of anyone doing work on EF interventions for kids with autism and what effect that may have on their adaptive skills?
Yeah, that if anyone's going to be doing that, I would imagine it's Lauren Kenworthy with the Unstuck and on Target and those interventions. I'm just not as aware of the research on it, but I would imagine that's out there. If it's not out there, it's coming. A lot of this, when I try to look for the resources clinically for my own clients, there's so much for supports there for children, but unfortunately not so much for adults. And so I'm always struggling to find executive functioning resources that help foster executive function for the older. But in trying to find that, executive function coaches are all over the place now. It's like, that's the new way to make money, right? So you just have to weed through those to see like what's legit and evidence-based.
Great, thank you.
Ellie, do we have time for one more question quickly?
Yeah, the one question was just asking if, and I can always email her the response, if you can recommend a diagnostician and or resources in the state of Connecticut to provide parental training and to assist my 20-year-old son in developing adaptive skills. They recently moved. That's from Stephanie.
Yep, there you go.
Yep. So that's the person that Stephanie is the woman with her hand up that asked.
Oh, I thought you were saying, yes, I do that.
No.
Okay. You know, Fred, jump in here if you know of additional resources, but I think Michael Powers' group does a lot in Connecticut. And then Rachel and Rebecca, I'm spacing on their last name, but the twins that have their own behavioral clinic.
I know who you mean. The other one I would add to this is the Department of Voc Rehab,
Yep.
which is not a horribly fantastic resource, unfortunately, in Connecticut, although it's getting a little better. But they might be a good resource. I do know there is at least one person on the shoreline who's been involved with some of the, she's a consultant on transition programs for some of the public schools. And she has had some good look. I don't know whether she does work herself, but I know she's a big person to push. And I'm blocking on her name, but Eileen may be able to come up with it.
And then you have Chapel Haven, one of the best in the country of transition programs that's just going to foster the real life skills.
Yep. And there's also Mills College. It's called, there's a part of Mills College, which I'm now blocking on the name of as well, Senior Moments right and left. But Mills College has a special needs program. And that's another program for kids as they get more towards the end of high school. That can be a good resource. The trick there is not to let your child graduate high school, but to get a couple of years of extra funding. Celine, thank you so much. This has been a fantastic talk. So people, please come to April and a couple of our various autism events. And then again in May with Peter Doring. And after that, we'll see you in the fall. But thanks so much, Celine. This was a fantastic talk.
Thank you. So great to see everyone. Take care.